Well, welcome everyone to this UHC Day 2020 webinar, the theme of which is accountability to the people to ensure health for all, protect everyone. And it's my pleasure as the Research and Policy Officer at IAS to have co-organized this webinar along with GMP+, the NCD Alliance, Unite, the World Hepatitis Alliance, and CSEM, which is the Civil Society Engagement Mechanism, to UHC 2030. It's a pleasure to have you all with us today. I just need to go through a few housekeeping rules before we kick off. In the chat, please feel free to say hello and introduce yourself with your name, organization, and country. And please feel free to post questions in the Q&A box specifically, and we will try to get to those throughout the webinar and verbally at the end as well. I would also like to introduce our moderator today, Carrie Jane, who is the World Hepatitis Alliance CEO, and he will take us through the rest of the webinar. Thank you, Carrie.
Brilliant. Thanks, Terry. And thank you everyone for joining today. Good morning, good afternoon, and good evening. I think that's the customary salutation these days. It's amazing to be here with all of you on the eve of Universal Health Coverage Day. And I think we've seen so much change in health systems over the last 9 months because of the COVID crisis, and they're going to continue to evolve. And the way that they evolve is really going to be crucial to the future of everyone and everyone's health. So we've got an amazing group of speakers for you today and a great panel. So I think I'm just going to go straight into it. I will introduce everyone as we go along. So our first speaker is Dr. Mimi Resima, and she is the program manager for NCDs at the National AIDS and Health Promotion Agency in Botswana. And she has more than 10 years combined experience in clinical service delivery and national public health work in Botswana. So Dr. Resima, over to you.
Thank you, Carrie. Good day, ladies and gentlemen, and thank you for joining us. I would like to take this opportunity to thank the NCD Alliance for the kind invitation and the opportunity to provide some perspectives on government accountability to the Health for All mandate in support of the theme of this year's UHC Day, Health for All, Protect Everyone. I wish to further extend my appreciation to the global network of people living with HIV/AIDS, International AIDS Society, Unite, Global Network of Parliamentarians to End Infectious Diseases, and World Hepatitis Alliance for the collaborative work in this important area. Sustainable Development Goals call on all of us to work on accountability approaches to advance universal health coverage. Countries are currently focused on the response to COVID-19 pandemic, which has devastated the society, our economies, and reversed some of the achievements in the health sector. Importantly, the pandemic has also highlighted the inequities that exist, and we now know that those with underlying non-communicable diseases have been disproportionately affected. Accountability isn't just taking responsibility. It involves a set of actions, attitudes, aspirations, and expectations that establish how an organization or agency should run, and to put processes in place to ensure that changes are made to improve decision-making and performance in future. Accountability for population level results, however, cannot be assigned to any one individual, organization, or level of government. One way to make sense of government accountability is to consider how we determine who should be responsible for what, by looking at 5 different levels and structures of accountability, which I came across as I was preparing for this talk. These are political accountability, bureaucratic accountability, citizen accountability, legal accountability, and professional accountability. This afternoon, like Harry said, we have a great lineup of speakers who will go on to discuss aspects of citizen, legal, and professional accountability. So I will limit my opening remarks to the political accountability structure, since they are arguably the strongest form of governance. Political accountability is a means to exert political control or oversight where appointed public officials are directly accountable to the executive branch with responsibilities in policy making ranging across sectors. At the same time, appointed public officials also possess a variety of authorities over rulemaking delegated from legislators. These responsibilities dictate that public administrators should account for their actions in the context of designing and implementing laws, rules, and regulations. These laws, rules, and regulations give direction to public administrators who are responsible for the functioning of a bureaucratic accountability system. Bureaucratic accountability is achieved by strategies, administrative rules, budget reviews, or performance management systems. In order to ensure government accountability to the Health for All mandate, accountability systems must do two things. One, identify possible actors and determine patterns of interaction. And two, develop the capacity of actors to support accountability. This implies the critical need for two enablers, that is, transparency being one, transparency to know the responsible actors, what it is that they're supposed to do. And then the second one is participation of actors that support accountability. Ladies and gentlemen, in regards to the disease burden in Botswana, in 2017, the top 5 causes of mortality were HIV/AIDS, ischemic heart disease, stroke, lower respiratory infections, and diabetes, with the main causes of mortality and their risk factors being primary healthcare issues. For this reason, we have made strides to address the prevention and control of non-communicable diseases, focusing at different levels. At policy level, Botswana has taken deliberate action to move the health promotion and disease prevention aspects of non-communicable diseases to the National AIDS Coordinating Agency, expanding its mandate and thereby changing its name to the National AIDS and Health Promotion Agency, NAPA. This outlook sought to elevate the importance and posture of NCDs by obtaining explicit high-level commitment to institute and strengthen national NCD work. The function of NAPA was also relocated to Office of the President. The objective of this transition was to leverage lessons learned during HIV and AIDS epidemic response, such as governance issues, financing, human resources, products and technologies, information systems, and community engagements to be translated towards the fight against NCDs. Since we know that many of the factors that influence health of the population may fall outside the authority of Health Ministry, Botswana, alongside many other member states, have committed and endorsed several high-level political declarations and commitments to establish and strengthen the multi-sectoral national policies and plans for the prevention and control of NCDs. The latest political declaration of 2018, which was themed Time to Deliver, Accelerating Our Response to Address NCDs for the Health and Wellness of Present and Future Generation, called for member states to upscale their response to the burden of NCDs. Last year, His Excellency, Dr. Mokgweetsi Eric Kiabetu Masisi, President of the Republic of Botswana, simultaneously launched the National Multi-Sectoral Strategy for the Prevention and Control of NCDs, as well as the National Strategic Framework for HIV and AIDS. These two documents will serve as a roadmap to discharge a coordinated response across ministries. They reflect recognition of the fact that accountability for the progressive realization of the right to health must be shared across government as a whole. At the launch event, His Excellency the President assured Botswana that his government has been proactive and efforts to address issues of NCDs are still continuing. the prevention and control of NCDs has been prioritized, which is underpinned by the high-level National Vision 2036, the National Development Plan, the Ministry of Health and Wellness Strategy, the National Essential Health Services Package included. However, His Excellency the President also acknowledged that more work still needs to be done. In countries like Botswana, we have limited resources and administrative capacity, and therefore cost-effective strategies are essential for prevention and control of NCDs. One would want to know how Botswana has planned the resourcing for national response to NCDs. The government of Botswana is the primary source of funding for NCD goods and services, contributing 79% of total NCD spending, while the private sector and household contribute 10% each. Last, but by no means least, borrowing from His Excellency the President's speech, it is also crucial to recognize the important role played by individuals, civil societies, and community-based services in contributing towards the health and development of a country. They participate in the implementation of national efforts and community-based interventions, most especially in the hard-to-reach areas. This makes it easy to integrate NCD issues from grassroots to national level. Government accountability requires policies geared towards encouraging community participation focused on the mutual empowerment of state actors, whose role is as reformists with the power over policy implementation, who create opportunities for citizen voice and for citizens to be engaged in public interest advocacy and collective action. The opportunity for change can arise from pro-accountability forces in the society or state. The key to success is the ability and willingness of counterparts in the other domain to support and empower others to act, especially because providers and state actors generally tend to have more power than citizens or clients. In November this year, the Ministry of Health and Wellness also launched the National Integrated Community-Based Health Services Guidelines in a bid to ensure that the basic health services are accessible to all. The guideline is premised on WHO, the World Health Organization, normative guidance and support for the restructuring and reorientation of Botswana's health services to ensure equity in access and service provision. As I conclude, ladies and gentlemen, the COVID-19 threat has been a rude reminder for us all to prioritize health and strengthen our health systems to avoid preventable deaths. Empowerment of communities and meaningful engagement of communities in policy and decision-making remains important in order to realize the commitments of universal health coverage and save lives. I look forward to today's discussions. I thank you all.
Thank you so much, Dr. Asima, and it's incredible work you guys are doing in Botswana. And I heard the word empowerment so many times, and mutual empowerment, which I think is so important as we think about moving forward together on this road to universal health coverage. So thank you so much. So our next speaker comes to us from Argentina, and it's Maria De Feo. And Maria is the president and founder of Fundación HIV Sin Frontera, with 20 years of experience formed by patients and relatives affected by chronic diseases, especially liver diseases. And she's also a member of the Civil Society Engagement Mechanism for UHC 2030. And today she'll be talking about the UHC needs from a community perspective, setting the stage. We have translation provided kindly by Cecilia Giannia. Maria, please.
Thank you, Gary. Voy a compartir esta pantalla, si querés decirlo. A ver, ok. No estoy compartiendo, ¿no? A ver, ahí va. Ok. Ok. Nuestra experiencia de trabajo durante este año de crisis sanitaria global nos permite observar que en Argentina y América Latina, en las comunidades, todas las poblaciones clave enfrentan un aumento de riesgo frente a la pandemia o emergencia sanitaria por COVID-19 y los impactos socioeconómicos adversos asociados han aumentado su vulnerabilidad. La vulnerabilidad de la niñez y la juventud se ha visto agravada aún más con la interrupción de programas de vacunación de muchos países, cierre de escuela y asistencia alimentaria en establecimientos escolares, entre otras situaciones. En general, y antes de la pandemia, hemos visto que es dolorosamente sorprendente el escaso conocimiento en las comunidades del derecho garantizado a la cobertura y acceso a la salud universal con que cada persona cuenta, y lo que este reconocimiento representa en términos de igualdad de oportunidades para su desarrollo social. Por lo tanto, muchas veces se comportan como si acudir a la atención médica fuera una molestia para los efectores de salud. ¿Celia? ¿Celia?
Yes, sorry. Okay, well, thank you very much for letting us participate in this webinar. So our experience in Argentina and Latin America during this year of global sanitary crisis allowed us to see that certain populations faced an increased risk towards the COVID-19 pandemic, and the socioeconomic impact has increased their vulnerability. Children and teenagers' vulnerability has been aggravated even more because of the interruption of vaccination programs in many countries, together with the closing of schools and the interruption of food assistance, amongst other situations. Even before the current pandemic, we have witnessed how amazingly painful it is, the total lack of knowledge from these communities regarding the guaranteed right to a universal health coverage that each person should have. They do not even know what this coverage means in terms of equal opportunities for their human and social development. Therefore, many times when they go to see a doctor, they feel as if the people involved in providing healthcare would be annoyed when treating them. Muji.
Sí. Otro problema grave en las comunidades que observamos es que el acceso a medicamentos esenciales, aun los que integran calendarios o programas de prevención de problemáticas de salud garantizadas, son de alto costo y muchas veces se interrumpe el stock necesario, y también las pocas farmacias comunitarias suelen ser una barrera muy frecuente para las familias. Las comunidades sienten gravemente las debilidades del sistema de salud, como es la prevalencia de lagunas de prevención, integración, seguridad y sustentabilidad. Se reflejan en la escasa retención de los pacientes dentro del sistema de salud, y una ausencia de coordinación entre las plataformas de atención interjurisdiccionales. Es paradójico observar que en comunidades de parajes rurales remotos de Argentina de bajísima densidad demográfica, 2,4 habitantes por kilómetro cuadrado, con un promedio de 5.000 habitantes, la mayoría de las marcas reconocidas de teléfonos móviles, motocicletas, bicicletas, cigarrillos están presentes en las comunidades, pero el sistema de salud universal continúa siendo una declaración y la infraestructura para canalizar la mentada y recomendada atención primaria de la salud una utopía. Celia?
Yes, another problem is the access to essential medication, even those that are part of a calendar or prevention programs, which are already settled. They are usually expensive and sometimes there is no available stock. While all the previously said is a painful reality, we must consider that in rural areas in Argentina, with 2 square kilometers and an average of 5,000 inhabitants as a whole, the most well-known brands are present: mobile phones, motorbikes, cigarettes, etc. On the other hand, UHC remains only as a declaration, together with the infrastructure needed and the primary health attention recommended.
Vemos en la fortaleza que implica para el sistema los trabajadores comunitarios de la salud, debidamente entrenados y provistos de los recursos e insumos necesarios, pueden salvar miles de vidas en la región de América Latina. La salud comunitaria es fundamental para ofrecer una cobertura sanitaria con equidad e igualdad. Los trabajadores comunitarios de la salud son personal de salud de primera línea, personas de confianza en y para la comunidad, que con capacitación y conocimientos básicos de salud pueden brindar atención primaria a sus vecinos. De todas formas, quiero mencionar que conocemos que en países, no podemos desconocer que en países de ingresos bajos y medios, los establecimientos de salud pública luchan por ser efectivos a pesar de la exigencia y limitación de la financiación pública. el personal médico insuficiente y los desafíos de abastecimiento y suministro de medicamentos y otros insumos para proveer a la comunidad servicios de prevención, diagnóstico y tratamiento, además de tecnología para el almacenamiento de datos y accesos a Internet. Así consideramos que es necesario definir nuevos paradigmas en atención comunitaria de la salud. Celia.
We believe in the importance of community health workers who should be highly trained and provided with the necessary resources. They can help saving thousands of lives in Latin America. Community health is fundamental in order to provide UHC with equity and equality. We understand that in countries with lower incomes, public health centers fight continuously in order to be effective, in spite of having a poor public financing, insufficient doctors and nurses, not enough medications, or even no access to the internet. However, we consider we need to define new ideas regarding community health attention. Muji.
En esta construcción consideramos que los gobiernos deben crear vínculos con los servicios dirigidos para la comunidad y las organizaciones de la sociedad civil, y garantizar que formen parte de las estructuras de gobierno de los programas de protección social nacionales y comunitarios, pudiendo hacer oír su voz. En esta la experiencia ha demostrado, la experiencia ha demostrado que es posible hacer que la salud comunitaria realmente funcione con un enfoque que garantice que personas supervisoras de salud tengan la capacitación necesaria y las herramientas digitales para administrar la fuerza de trabajo remota en tiempo real y articule con los establecimientos de salud cuando corresponda. Celia.
We think the governments must develop a bond between the services directed by the community and the civil society organizations in order to be heard. Experience has shown that it is possible to make community health work once it is guaranteed the people involved have the preparation needed and the digital tools to manage the workforce remote in real time.
Consideramos que es necesario el trabajo en cooperación con sociedades civiles para alcanzar acceso a la salud en las comunidades, aunque sus misiones estén dedicadas a enfermedades particulares. Con este objetivo, durante el mes de octubre y noviembre, parte de la sociedad civil argentina, miembros de CESEM, Todo Frente al Chagas, Fundación Huésped y Fundación HCB Sin Fronteras, realizamos en nuestro país un ciclo virtual denominado Un Horizonte para la Salud Argentina, fortaleciendo lazos intersectoriales, ciclo que contó con el aval del Sistema de Naciones Unidas en Argentina y de la Universal Health Coverage Coalition, en la cual participaron destacados actores del gobierno nacional, las sociedades científicas y la sociedad civil para detectar objetivos comunes compartidos de acción en la salud, reforzando el rol esencial de las organizaciones de la sociedad civil para la cobertura sanitaria universal con un enfoque en derechos humanos.
It is important the cooperation between the civil societies in order to provide access to health for the communities, even when they have different missions and are dedicated to a specific disease. Towards this objective, during October and November, some members of the Civil Society Engagement Mechanism for UHC 2030, CSEM, in Argentina, participated in a virtual event called An Horizon for Health in Argentina, Strengthening Intersectoral Bonds, under the sponsorship of the United Nations System in Argentina and the UHC Coalition. In this event participated important government representatives, scientific and civil societies.
El fin de este ciclo fue realizar un documento estratégico de acción frente a los desafíos del sistema de salud ante las emergencias sanitarias en Argentina, que puede ser de utilidad para otros países de la región en el marco de la meta 3.8 cobertura sanitaria universal del Objetivo de Desarrollo Sostenible 3. Un documento preliminar será difundido mañana, el próximo Día Mundial de la Cobertura Sanitaria Universal. En el ciclo abordaron diferentes temas referidos a políticas públicas, economía, el rol de la sociedad civil y estrategias futuras para alcanzar la cobertura sanitaria universal. Celia.
The main goal of this event was to develop a strategical document about the challenges of the health system facing the sanitary emergencies in Argentina. This document can be helpful to other countries in Latin America. Also, a preliminary document will be released in the next UHC World Day. During the event, different topics were discussed regarding public policies, economy, the civil society role, and future strategies towards reaching UHC. Muji.
Es importante destacar que todos enfatizaron la importancia y necesidad de participación estratégica de la sociedad civil para alcanzar la cobertura sanitaria universal, mencionando que en emergencia sanitaria por COVID-19 se ha visto la importancia de la participación de las organizaciones de la sociedad civil en dar respuestas inmediatas e integrales sobre salud, atención alimentaria y vincular a la comunidad con la atención sanitaria, pero que no solo resulta esencial en la emergencia, sino que debería ser un aliado estratégico del Estado en el proceso de transformación que necesita el sistema de salud, que puede llegar con más facilidad a la comunidad y articular en el Estado los cambios que son necesarios. Celia.
Everybody emphasized the importance and necessity of civil society strategic participation in order to achieve it. During the COVID-19 sanitary emergency, it has been witnessed the importance of the participation of the civil society organizations towards giving an immediate health response and food assistance. This is not only important during an emergency. Civil society organizations should be a part of the transformation process the health system needs, so that it can be easier to reach by the community and work together with the state in order to develop any changes that are needed.
Y por último, quiero agregar que la sociedad civil tiene un rol muy claro que tiene que ver con poner temas en agendas gubernamentales, con sensibilizar y capacitar permitir a donde el Estado no llega. La veeduría, el monitoreo, la validación de las propuestas son parte también de sus funciones, pero por otro lado, hay otro rol muy clave, que es tener incidencia en las políticas públicas para lograr ser un puente entre las necesidades reales de la comunidad, las estrategias sanitarias para no dejar a nadie atrás.
Okay, so civil society put important topics in the government's agenda, and the monitoring and validation of proposals are part of their functions. Another key role is having incidence in public policies, acting as a bridge between the real needs of the community and the sanitary strategies so that no one is left behind. Thank you very much for your time.
Thank you so much, Maria and Celia. I mean, I think there's so many powerful things in what you said about the power of community and the essential nature that human society must be included in UHC. And saying, UHC is only a declaration. I mean, how many countries in the world, unfortunately, can also say that. So I think that's a really big, statement to make, that we need to make UHC a reality, not just on a piece of paper. So thank you so much. So we've gone from Africa to South America. So now we're coming to Europe with Sasha Volgina, who is a program manager at GNP+. And Sasha is one of the co-founders of Front AIDS, which was the first treatment advocacy movement in Russia, and co-founded Shveka, which was one of the first community-based organizations. And as program manager at GNP+, she focuses on stigma, discrimination, and criminalization through coordinating the global partnership to eliminate stigma and discrimination. So Sasha, over to you.
Thanks a lot, Carrie. Thanks a lot for opportunity to be here today and to speak. I really appreciate a lot what Maria was saying about the role of the civil society and the communities in the response. But my presentation today maybe would be focused a bit on a more personal view on the UHC. Though I think we are players in that game, we are one of the actors and one of the stakeholders. My colleague and friend Consolata from Nairobi, Kenya, from the 9th till 25, she was getting her HIV care in a health facility which was run by MSF Belgium. So what she is saying, I got my IRVs screening, my contraceptive, hepatitis B vaccination. I had checkups for TB when I had bad coughs, treatment for any opportunistic infections. And I got my biochemistry done. Everything was provided in one place. And then MSF have moved and it became a governmental hospital. And since that time, she was to move hospitals since the facility no longer was offering the services she used to receive there previously. Not even counseling. She's saying that she still gets her IRVs easily, but she has to push for biochemistry, which is no longer free. So it's out-of-pocket payments. If she has cards, they screen her for TB, but she had to pay for it. It wasn't so easy when it was so easy when she was at MSF clinic. Everything was integrated. I trusted my doctors. I didn't have to worry about money for my treatment or testing. Things are so different now. And it's quite a hassle just to receive a quality integrated level of treatment and care. Now it is an effort, and I have to try to keep on top of that. The next story is actually about myself, because I was born in Russia, then I lived in Ukraine. Now I'm based in Netherlands. I have heart disease, I have kidney disease, I have hepatitis B, C, and D, and of course HIV. So I was using drugs previously, but staying clean for several years. And when I arrived to the Netherlands, I was offered to try to treat my hepatitis D with interferon. I discussed my addiction with my doctor, but wasn't offered any antidepressants or any support for mental health. Though interferons are known to cause depression, I asked about it, but I didn't insist on it, thinking that doctor knows better. So I was getting my hepatitis D treated, but not dealing with the fact that I also have an addiction and have many mental health issues. This led me to depression. Then I waited for an appointment with the psychiatrist for a month, which led me to relapse. And I ended up in psychiatric care for 2 weeks. My care didn't take into account my full life situation. In Eastern Europe, there is a push to integrate HIV, TB, hepatitis, which was quite successful. But what we lack is integration with the addiction care, with mental health care, and with harm reduction services. It's only community organizations and NGOs who are trying to make training models for both three diseases, and it is still not supported from the governmental side. Also, stigma and discrimination is a big barrier. For the whole region, basically, stigma and discrimination have built a parallel medical system. Back in the 90s, there was established a system of 8 centers in Eastern Europe and Central Asia. So basically, all the medical needs were covered there, but it is not possible. It has to be integrated. And it still faces a pushback even from the side of the patients. And I do understand the patients, because, for example, in Armenia, they were going to integrate care into the primary care and just to reform the 8th center. And there was a pushback from the patients, because people were afraid to go to the primary care, because they were afraid that their HIV positive status would be disclosed. And they were fighting for their 8th center to be back. At the same time, this year in Armenia, women were to go to the capital of the to give birth, because it's the only place where they have a hospital for HIV positive women to give birth. So here's the dilemma there. And we have to reduce stigma and discrimination. Otherwise, we just won't be able to integrate the healthcare. Sorry, with the slide. In Europe, with the general practitioner, I have general doctor who knows the whole picture. There is at least one person on earth who knows everything. Before, my heart doctor didn't know I have HIV. My hepatitis doctor doesn't know about the heart. Specialist after specialist after specialist. Even here in Western Europe, even if there are mistakes, the system is more connected compared to the Eastern Europe. And it is free from stigma and discrimination. For example, my doctor in Netherlands was seriously discussing with me an opportunity of liver transplantation. This is impossible to imagine in Russia, as HIV positive people are excluded entirely from any transplantation program. What makes integration work and comprehensive care work? Health providers have to take the opportunity to ask about other health issues and can proactively signpost to other services. Healthcare providers who know what they are doing and are friendly, open, and non-judgmental. At least one healthcare provider who knows the full story and then refers you to the specialist care when you need it. Peer supporters are well supported and resourced to be able to assist peers with information, to encourage them and connect them with the services. Tests and diagnostics have to be free, not just medicines. Stigma and discrimination have to come to zero, otherwise it prevents people from coming to get help. What doesn't work? When healthcare providers just see you as one disease and don't see you as a person with many health needs. Engaging with the multiple specialists, which take up time and you have to tell your story over and over and over again. Out-of-pocket payments can screw up even great success in treatment access. In some contexts, physically separating people living with HIV in a health facility or making parallel medical systems for HIV-positive people. And also when we have high stigma and discrimination and paternalistic approach. I'll stop here. Thank you so much.
Thank you, Sasha, and thank you for sharing your story and so vividly illustrating why we really need, patient-centered care and a patient-centered approach, and that, integrating one or two elements of that, might help a little bit, but it's not really going to get us to where we want to go. So thank you so much. Our next speaker is Maka Gorgia, and she is Program Director at the Georgian Harm Reduction Network. And during the past 12 years, she's engaged in advocating for better accessibility to HIV, HCV, TB, and STI treatment and preventative services for key affected populations. So Maka, over to you.
Hello to everyone. I'm trying just to find my presentation. So difficult. Can you support me with Terry with your one presentation? I can't see it.
Yes, I will try now, Maka.
You always type just when you need it.
Yeah. Maka, I don't seem to have your slide.
Oh, I will try once more. Oh, what to do? I don't know.
Мака, открой саму презентацию, а потом зайди обратно в Zoom и включи share screen.
Maka, let's...
Done. It's done.
Okay.
Done. Yeah. So in my presentation today, I will talk about the story from Georgia and Georgian civil society organizations that are highly engaged in provision of integrated services for high risk and marginalized groups. Very briefly about Georgia and the communicable diseases, Hep C prevalence in Georgia is highest in Europe region, 7.7, Hep B prevalence also significant till 3% in general population and low HIV prevalence. From the very entry point of the epidemics of those diseases, civil society organizations play a significant role, not only in screening, but in referral, linkage to care, long-term adherence, and patient education. Georgian Harm Reduction Network that unites 26 NGOs is playing important role in ensuring health and social welfare of people who inject drugs, living with HIV, viral hepatitis, TB, or they are affected with these diseases. We all know the importance of civil society organization and how they have advantages over governmental agencies. Here we have the same in Georgia. Our civil society organizations have richer experience working at community level. Their autonomous nature allows them to respond more quickly. They have access to marginalized groups. They generally work with the target groups to raise their self-esteem. They can act as a bridge between the community and at the national level. They often employ innovative methods, and their method of operation allows for cost effectiveness. The marginalized groups for Georgia are defined as people who inject drugs, MSM population, sex workers, and prisoners. And within this great support of the Global Fund, those populations are ensured with the comprehensive services that are highlighted here on the left. We have 14 harm reduction sites and 14 sites for MSM and sex workers throughout the country. The history of harm reduction itself and this comprehensive services started from early from 2001 with the prevention program of HIV as a harm reduction program, and later different diseases came into action and joined this program from 2000. Hepatitis C, hepatitis B, and syphilis was available by civil society organization. Then take-home naloxone entered into action. Then from 2013, TB screening and linkage to care also took part at our harm reduction program. And later, from 2018, Hep C diagnostics and treatment started at harm reduction sites and currently is available here. I want to mention this very interesting innovative program that is taking place within the support French 5 initiative with main partnership of Alternative Georgia, and GHRN is taking the role in it. So within this trial, it's already available different kind of service packages for different target groups, drug users, MSM population, trans population, and include the various range of packages for opioid users, stimulant users, male condoms, also home naloxone, female condoms, pregnancy test, and the last one that was added recently, HIV self-tests. So these machines are used to reach community members right in the streets. And currently there are available already 10 machines throughout the city, the capital. Of our harm reduction program staff, I mean outreach workers, are community members, and they are the very valuable persons for the program, as they are quite well trusted by the community itself. They have quite good connections, networking, mobilization skills, and they know exactly who are their clients, what their clients need, how to deliver the services, and when to reach them. These are ordinary sites of our harm reduction centers in Tbilisi. This one is from Batumi, another big city of Georgia. And this is our organizations that are providing testing services at our trip. Within the European AIDS and hepatitis testing week, we are providing free screening services, not only for marginalized groups, but for general population as well. This is our innovative approach to avoid police attention of our services to reduce stigma and self-stigma among community members, and to reach unreached population and covered by before. This is a short about the case that was acknowledged as a success story of community-based testing in Georgia, and you can find it on internet and see the full story of the success. As I mentioned, from 2018, we started integrated Hep C treatment program within national Hep C elimination program, and at our harm reduction sites at the low threshold level, we have screening together with point of care diagnostics, I mean gene expert testing that gives possibility to give patients, the clients, the confirmatory diagnostic results in 90 minutes. And we have possibility at 4 harm reduction sites to initiate Hep C treatment in the same day. So all the procedure is taking place in one day. So we try to reach community members, drug users, and provide the full package of services in one window model. And I want also to highlight the importance of case management model that enables program clients to reach from lower level to the needed specialized treatment and care points using different stages of risk counseling, providing them screening and post-of-care diagnostic, and referring them to the needed treatment sites. I mean, treatment of those diseases like HIV, Hep C, syphilis, TB, and of course, opioid substitution therapy, linkage and the social adherence to be involved timely in this program. These are our patient school that we call, and we are gathering community members at our harm reduction sites and provide them targeted training and education on the topics interesting for them on HIV, Hep C, Hep B, TB, and overdose as well. Of course, we have challenges together with achievements within the program, and the first one and important one is criminalization of drug consumption, marginalization of risk groups, stigma discrimination, including by medical personnel, lack of innovative and supportive programs to reach hidden population. Before, when we had a different kind of donors to fund such innovative programs, we had less problems, but now when the global fund is leaving the not country but all the region, entire Eastern European and Central Asian region, we have deficiency of funds, and we have a difficult period of transition after global fund, and we are taking our first steps to use the state funding for the comprehensive services for these groups. And another problem is we have increased number of testing indicator year by year by donor and the state. And we have a need to develop new services that does not exist within our harm reduction program currently. This is a special services for non-injecting and new psychoactive substance users. This is chemsex services. This is services for queer women and trans people, for services for youth separately, and mental health services for people living with HIV, including children. That was my presentation. Sorry if I took too much time from you. Stay healthy. And thank you for your attention.
Thank you. No, not at all. We're in fact 2 minutes early. That was terrific. And it's just, you know, and I love like the innovation that you're doing in Georgia, like the vending machines, and just in terms of the service delivery, it's incredible. So, I mean, I'm just really in awe of the work that you guys do. So thank you so much. So our next speaker is Margaret Crook, and she is Professor of Health Systems at the Department of Global Health and Population at the Harvard T.H. Chan School of Crook's research generates evidence on how health systems can improve health for people living in low-income countries. So Dr. Crook, over to you.
Good day, everyone, and thank you so much, Carrie, for the introduction. What a delight to be with all of you today. I'm really inspired by the words and accounts that preceded my talk, and hopefully some of the concepts we'll be talking about in the next few minutes relate quite closely. So I will be speaking from the perspective of someone who studies health systems and how health systems can, in fact, and need to become much more accountable to people. All right. So I want to start with the premise of what is the health system for? And I think one thing we've heard throughout the presentations thus far is that simply having a clinic, simply having UHC on paper, or even a doctor who will see you is simply not enough. And I want to just make the point with this slide What you see on this slide is countries that have achieved tremendous levels of coverage. In fact, nearly universal coverage for mothers who are delivering babies in clinics. And yet the bars represent newborn mortality rates in those countries. So you can certainly see that a delivery in a clinic in one country is not the same as a delivery in a clinic in a different country, in that harms can still accrue to mothers and newborns. And we see excess mortality despite having excellent coverage. So what does this mean? What does this tell us about the health system? Well, it tells us that what we need is more than a system on paper or a clinic that's barely functioning, but really what we're looking for is a high quality health system. And what we have done over the past several years is try to define what that is. We created a commission that published a report back in 2018, the Lancet Global Health Commission on High Quality Health Systems, that was comprised of people from all over the world, from 20 countries, and really tried to get at the question of what's a health system good for and how should it look. We started with the premise that health systems are fundamentally for and about people, and that a high quality health system optimizes health in a given setting by doing three things. Consistently delivering care that improves health. I want to emphasize consistently. All health systems have points of excellence. Here we're talking about everywhere, every day, whether it's 2 p.m. in the capital city or it's 8 p.m. in a small village in the north. Second, a high quality health system needs to be valued and trusted by all people, not just people with means, but the population as a whole. And lastly, a system is not a pile of bricks or a set of clinics. It's a living organism that needs to respond to changing population health needs and crises, just as we have seen with COVID. And what I would argue is that at this moment in time, there's more pressure on systems to transform than ever. And that's for three reasons. One is that our health needs are becoming more complex and they're becoming greater. We heard from our colleague in Botswana that the top killers in Botswana are no longer infectious diseases, except with the exception, huge exception, of course, of HIV/AIDS, which is really a chronic disease in 2020. But that there are the same types of conditions that we would see here in Boston, that you would see in Europe, that there are more and more complex health needs. We've heard about people with addiction. We've heard about people with mental health needs. More and more pressure on health systems to do a good job, not on one visit, but over the course of care. Second, because of the many wins that we have experienced in countries, and many countries have had tremendous progress, have shown tremendous progress in reducing mortality from amenable, preventable conditions, the lower levels of mortality that we face today mean that the next step is harder. Residual mortality is harder to avert. And the third reason why systems are under pressure is that everyone's expectations are rising. Now that we're all connected, WhatsApp can quickly transmit information about a bad clinic between family members or friends, and the expectations on health systems are rising. Systems of yesterday will no longer meet the needs of today, or certainly not tomorrow. In our team, we estimated that when you look at mortality rates from treatable conditions in 137 low and middle income countries, which of course is the majority of the world, and compare those to mortality rates for the same conditions in well-functioning health systems in high income countries, you can count up 8.6 million excess deaths a year from treatable conditions every single year. And that includes HIV/AIDS, for which we, despite the presence of extremely effective medicines, have not been able to retain people in care, to provide care to everyone who needs it, and to achieve the quality that we know we need. Now, among these 8.6 million people who lose their lives every year from treatable conditions, what we were able to estimate is that about 60% come to clinic. 60% come to clinic. What does this mean? The clinic is not doing its job in saving that life. So already poor quality of care, and not just lack of access, which has been the focus of the last 20 years, but poor quality of care is a major hindrance toward realizing our shared ambitions of better health. I want to just zoom in a little bit on why and how this is manifesting in the health systems of many low and lower middle income countries. Each of the dots on this slide is a country. And what we have been able to do is gather data from clinical observations that look at what providers are actually doing for people. And I'm going to come back and argue that this is one of the transformations that has to happen. We have to stop counting providers, stop counting clinics, and instead look at what they're doing for people. So when you do that, what you realize is that for very routine services such as family planning or sick child care, we are seeing about 40% of the needed clinical tasks getting done in a visit. Half the mothers that bring a sick child into care in many, many countries walk out without any diagnosis whatsoever. Those people do not know what's going on with their child or what they should do next. And we see the same failures across conditions. I want to also emphasize this point, which has come up repeatedly in today's talks, which is that the poor typically get the worst end of that spectrum of poor quality care. In this slide, we have subdivided populations in various income regions by wealth, with blue, this blue being the poorest 20% of the population. And you can just look across services, whether it's antibiotics, whether it's oral rehydration therapy, blood pressure being taken, or vaccination, that for many conditions, the poor actually do the worst across the countries. Not for every condition. We see some similarities, for example, here, but in many conditions. So technical quality of care, the very basic a deal that the health system makes with people, come to us and we will do the right thing for you, is not getting done. But what's also not happening is a respectful experience for people. What we see here is based on numerous data points and studies from across countries, and I think this group is very well positioned to comment on this as well, is that people experience disrespectful care, short consultations, poor communication, or very long wait times. I've just cut and pasted some quotes from qualitative work showing the types of experiences people have. And we've already heard examples. We've already heard examples of the doctor not knowing anything about your last set of test results, treating you like a disease, I think I heard from one of the panelists, and not a person. And I think this is a very routine experience in health systems. So poor technical quality, poor knowledge and skills, but also poor treatment. So how can we shift health systems to be more accountable to people? In our commission on high quality health systems, this was our North Star. What is it that people need the health system to be doing differently? The first thing is that systems need to measure what matters and when it matters. Now, this may seem a little geeky, this may seem a little academic, but I would argue it's at the very center of accountability. If we are measuring things that don't matter, they may look quite good on the surface. And for accountability to be there and to be real, we need to be measuring things that are much more meaningful to users. So what are some of those things? Well, functions, not inputs. Let's understand what systems are doing for people in the example that I gave earlier, what clinicians are doing when they see a patient in front of them, whether clinicians are actually competent, not just counting how many there are. Let's also measure performance in normal times and in crisis times. Our team, together with 15 countries, have been trying to track service provision for regular health needs, including, for example, HIV care during COVID, because a good health system doesn't just drop everything else it's doing to tackle a new threat. That would be a disaster. So performance in normal times and crisis times, we need to see, people should be seeing what the performance of the system is for all health conditions. People don't choose what they get sick from. And then the last area of measurement, and we'll come back to, is the notion of people's voice and people's values. How do people experience the system? What's the level of confidence that they have in their health system? Would they endorse that system? Would they recommend it to others? And are there real feedback channels, not fake ones, not suggestion boxes that no one ever checks, but real feedback channels that are attended to? I want to give you an example of a question, a very straightforward question that is very informative to me about people's confidence in the health system. This one we asked in Liberia many years ago now, in 2008, so before the last Ebola epidemic, but after a civil war there. We asked a simple question: if you or your child are very sick tomorrow, can you get the healthcare you need? And what you can see here is that fewer than half of Liberians answered yes to this question. I think this is a standard question that should be asked in every country. We need to know how many people feel that the system is there to help them tomorrow, because certainly that sense of security is one of the key values of any high quality health system. Second, we need to move beyond what I call micro level fixes. I think what we see very commonly is when problems are diagnosed in the health system, quality problems are diagnosed, our instinct is to give the provider a reminder, give them an app, give them a week training maybe, try a little incentive payment, maybe a 10% bump if they do a good job. What we see from those kinds of efforts is very little. We see that and we've done research on this and others have done research on this, that they fundamentally might shift behavior by a little bit in that set of clinics, but they do not fundamentally change the nature of the system. We need to be looking at major structural reforms that tackle the foundations of the health system, tackle the training of health workers, are much longer term and larger scale. And critically, they're nationally led. They're not dictated by the World Bank. They're not dictated by international organizations. Hopefully they're aided and assisted by those organizations, but are nationally led. And so what are those kinds of changes that I'm calling for and we're calling for in the Quality Commission? A shift in governance with a much greater set of channels for accountability. And we heard about those from colleagues prior. We need to modernize health provider and health manager education to be much more about patients, much more about teams, and much more about modern ways of training people to practice medicine and nursing. We need to redesign service delivery. Why should we be sticking with models of care that were inherited in many countries from colonial times? They're 60, 80 years old, when we've seen during COVID the kinds of transformation and adaptation that can happen quickly. Let's rethink what primary care is good for. Let's rethink where care should be provided for laboring, delivering women. Why should the standard of care for those women be so dramatically different in Kenya than it is in the United States? It's time to rethink those expectations. And lastly, and I think this is really the focus of our session today, is we need to involve the population in the transformation of the health system, which I call igniting demand. So let me say a few words about that. Every service sector, with the exception of the health system, cares about what users think. Every service sector seeks user feedback to improve itself. I do not see that being done regularly in healthcare, but I don't see why it should be any different. Users bring a tremendous amount of perspective to what happens in healthcare. And we see this shifting and changing slowly. In increasing number of high-income countries, certainly in the United States, there is a greater impetus to collect user feedback regularly every year, to collect users' own outcomes and own perception of how they're functioning as a measure of quality of care, and not just the blood tests, but are you able to go to work? Are you feeling okay? Are you depressed? So patient-reported outcomes, patient-reported experience are rising in importance in many countries. And I think that's exactly the direction we need to go. But here's a problem, and we need all of you to tackle this problem. Let me explain what's on this slide. Today, the expectations for health systems are far too low. What you see on this slide is an experiment we did in 12 countries that are listed here. It was an internet survey. So keep in mind, these are internet users who may be even the more sophisticated users and more educated users in these countries of health systems, where we gave them a scenario about Anthony, who goes in with a high blood pressure for a regular checkup. The nurse does not do any assessment whatsoever and changes his medication. Okay, that's all. Over 50% of people in most of the countries thought this was good, excellent, or very good care. So look, I'm a doctor to begin with. I'm not going to be able to do this revolution by myself, but we need all of the groups that are represented here today to shift what is the expectation of good quality care. Because if users start with such low expectations, both in terms of knowledge and competence, such as in this one, or expectations that they'll be treated poorly, they're going to come out of that visit and think that wasn't so bad. I'm saying we need them to think that was pretty bad, and we need to do something about it. So we all actually need to unite together to collect these data, to be able to, and more importantly, that's the part that we can help with. But what we can't help with, and where we need you, is the community organization, the patient groups, and organizations concerned with accountability to be shifting the expectations for higher quality care. And that's not so straightforward because many people want more medicines, maybe people want more procedures. So there is an education element that's required here. But I don't think that we can get to high quality health systems without it. And so with that, I just want to thank everyone. It's been an absolute privilege to present alongside the many excellent panelists, and I'm delighted to take any questions.
Excellent, thank you. I mean, I wrote down so many things from your presentation, but I really love that every sector cares about customer satisfaction except for the healthcare sector. I mean, that's such a powerful statement. Maybe that's not exactly what you said, but you know what I mean? That kind of feeling that customer satisfaction is, you know, it's so much higher in other service industries. That's incredible. I was at a meeting the other day and we were talking about, you know, patients dropping off from having a screening test to a you know, this confirmatory test. And, you know, they were saying, what can we tell these patients that will get them to come back? You know, they had to go to another clinic on the other side of town, right? You know, the answer is not, how can we get this patient to go to the other side of town? The question is, how can we get that test in the same place? You know what I mean? How can we improve the system to better serve the patient rather than how can we improve the patient to better fit into the system? You know what I mean? I think that's such a powerful, powerful message. So thank you so much. Thank you so much. Okay, great. So that concludes all of our presentations. So we're now going to move into the second part, which will be a discussion, and we have some polls for everyone to take part in as well. So, so the audience can still post questions in the Q&A box, and then we can ask them during the panel session. We're not going to answer questions verbally. We're just going to read them from the box, and then I'll present them to the panel. And joining us on the panel, we have a few new people. So Terry is going to do a double role as host, and also is going to join the panel from the International AIDS Society as part of her role as the Research and Policy Officer. Grace Dubois is going to join us as the Policy and Research Manager at the NCD Alliance. Victoria Gransolt is the Executive Director of UNITE, which is the Parliamentarians Network fighting infectious diseases. And Jessica Hicks is the Head of Programs for the World Hepatitis Alliance. So welcome to all of you. So first, Terry is just going to take us through a few poll questions. So Terry, I'm going to hand over to you.
Thanks very much, Carrie. So I'm going to launch the first one. What you do is you just need to vote for one of the three possible answers to the question. I'll give you all some time to make a decision before you vote, and then we'll just have a very brief discussion about the correct answer. There's only one of the three that are correct. So please go ahead and vote. I hope you can all see that on your screen. So the UN Political Declaration of the High-Level Meeting on Universal Health Coverage, Moving Together to Build a Healthier World, that was in September 29, reaffirms that. And then there are three choices. Healthcare expenditure by governments must be supplemented by out-of-pocket expenses. Health is a precondition for and an outcome and indicator of all three dimensions of sustainable development and the implementation of the 2030 Agenda for Sustainable Development. Or UHC refers only to basic healthcare outside of outbreaks, epidemics, health hazards, or emergencies, which requires supplemental services. I'll just give you a few more seconds to answer that. We've reached about 50% voted. I'll give you a few more seconds. All right, I will end the poll now. Right, you should all see results now. So 14% voted for number 1, 82% overwhelmingly number 2, which is the correct answer. So very pleased to see that. And only 4% for the last one. So yes, indeed, health is a precondition for and an outcome and indicator of all 3 dimensions of sustainable development and the implementation of the 2030 Agenda for Sustainable Development. In reference to the first answer, which is incorrect, no healthcare expenditure by government should be supplemented by out-of-pocket expenses. There should be no out-of-pocket expenses. And again, UHC does not only refer to basic healthcare outside of outbreaks. Healthcare should include all necessary health services in times of for normal primary and hospital care and in times of outbreaks such as the current pandemic. All right, so I'm going to allow the panelists to briefly weigh in if they would like to on this poll before we go to the next one. If anyone should want to comment, perhaps I will address this one to Margaret.
Terry, are we looking at the chat, sorry, or the Q&A?
The poll, the results of the poll.
Oh, I'm sorry. I think it's no longer on my screen.
Okay, no worries. We will move to the next one.
Please.
That's probably my fault.
Disappeared.
All right. Second poll. Apologies, I'm just checking why did it come up with the second one. There we go. All right. So the second multiple choice is the Civil Society Engagement Mechanism, or the CSEM, of UHC 2030 was set up to provide civil society organizations with a mechanism to represent their constituencies, specifically include only identified UHC advocates in the CSEM, in the UHC 2030 dialogue, or promote only one advocacy message, leave no one behind. Please feel free to vote. Got 50%, so maybe a few more seconds. All right, closing the poll. All right, so again, we have an amazing audience because the majority of people voted for number 1, which is the correct answer. Provide civil society organizations with the mechanism to represent their constituencies. The second one, specifically include only identified UHC advocates, is not true. You do not have to identify as a UHC advocate specifically to be involved in the CSEM. Other advocates and civil society members are welcome. And promote only one advocacy message is not true. There are a number of very important advocacy messages being promoted by civil society and the CSEM, all of which are important. Again, I invite the panel to weigh in. Whoever wants to make additional comments, you're welcome before we go to the next poll.
I mean, maybe I could just say something since I'm on the advisory group just quickly. I mean, I think the real important thing about structures like the CSEM is that, there aren't many civil society organizations in the world dedicated to universal health coverage, right? It's been an organic process, really started, civil society in terms of a huge structure has really been nurtured by the HIV response and the TB response. And, there's NCD, civil society organizations, so everyone kind of has their own little area that they're concerned with. So I think the idea of how do we come together in this movement towards UHC is such an important question. And I think at the CSEM is really about, how do we come together? How do we still, fight the good fight for the communities and for our causes, but also have a view for the bigger picture? And I don't think we have the answer to that question yet, but it takes like little steps like this, these events, these kind of sharing things, and for us to start looking at the wider picture that could really make that happen. And that's why I'm so happy that we're part of this event today. We could make this happen, and that the CSEM is there going forward. Thanks.
Thanks very much, Carrie. All right. Apologies. Goes the next one. So the last one is about the People's Voice report, which was a civil society response to the report of the Lancet Global Health Commission that Margaret mentioned on high quality health systems in the SDG era. Did the People's Voice report recommend that voices of non-health professionals cannot be recognized as equally valid as any health expert? That excluding the private sector from discussions is a good idea, as they cannot be included within rational healthcare decisions or regulatory mechanisms across sectors? Or finally, recommended 5 necessary next steps, including avoiding tokenistic social accountability mechanisms. Please go ahead and vote. Right, nearly up to 50%. Right, I'm going to end the poll. Well, so again, most people voted correctly. 5 necessary next steps were recommended, including avoiding tokenistic social accountability mechanisms. So I will just clarify for 1 and 2 that the voices of non-health professionals must be recognized as equally valid as any health expert. And that the private sector should be included in discussions, particularly in countries like India, where they provide a lot of care and where people move in between the public and private sector. Once again, we're inviting the panel to weigh in should they wish to make comments.
Yeah, I'd be happy to. We were really delighted to have this this report that really got contributions from around the world and from very many different groups, in part as a demonstration of our basic hypothesis that health systems have to be about people, have to speak to people. And so, we are of course all health system users, including myself and all the commissioners, but really wanted to get that other perspective, not the academic perspective or the expert perspective. And we felt that this, the points you've just highlighted in the poll, that there are, that users of systems, and frankly, I would also include non-users, people who avoid health systems, are legitimate observers, legitimate commentators, and legitimate judges of how health systems perform. As one example of something that has happened since the report and based on some of these recommendations is that we're in the process of developing a new survey instrument called the People's Voice Survey, which will actually poll the population, not just health system users exiting clinics, you've seen those exit interviews, but really the entire population to say, how is the system working for you? Which public or private facilities do you trust? And where would you go if you had this need? So we're really excited about this as a rigorously developed, valid and comparable tool that can be used across countries.
I'd like to just add on Margaret's point there. We, NCDA Alliance, are really enthusiastic to learn from the HIV community, particularly with how this person-centered people's voice has come through and led things forward. We've been really encouraged by the WHO also picking up the mantle and engaging people living with, not just in the evaluation processes, but also the policy planning processes. And actually currently there's a consultation for people living with NCDs, learning from different disease groups being run by WHO over 3 days. So we're really excited to see some of these multilateral, global institutions taking this on.
Yeah, if I can quickly build on to what Grace and Margaret have said, I think it's the exact same thing that we've seen in the hepatitis space over the last couple of years, is that this idea of tokenistic engagement really has, people have acknowledged that that has to stop, and that engagement with people living with viral hepatitis and HIV NCDs has to be meaningful, and they have to not just have a seat at the table, but they have to be leading the discussion. You know, we can't be designing health systems for people with just a little bit of a side consultation for those people. They have to be front and center.
Great. So was that the last poll, Terry? Are we moving on?
Indeed it was. Thank you so much.
Great. So Victoria from Unite, the Global Parliamentarians Network to End Infectious Diseases, I know you'd like to say a few words about accountability, so please.
Yes, thank you so much for the invitation to present today and to represent on behalf of the Unite Network, especially following these great interventions. So to briefly introduce Unite, it is a peer-led global network of current and former parliamentarians who are committed to ensuring that no life is limited by infectious disease through unified political advocacy. So our network has representation in 65 countries, and it is through the Unite Secretariat based here in Lisbon that we actively engage parliamentarians on issues surrounding global health, infectious disease elimination, and universal health coverage. So at Unite, we believe that we can effect tangible change through uniting the voices of parliamentarians across the world beyond ideology. And we call on our global network of parliamentarians to hold governments accountable and to commit to the use of political levers, such as resource allocation and the promotion of cross-party collaboration to improve global health. And so with this unique and critical role of parliamentarians as a central figure between key stakeholders, their political leadership and accountability are crucial in advancing progress towards achieving universal health coverage for all. Particularly now, against the backdrop of the pandemic, there lies a unique opportunity for parliamentarians to demonstrate political will and accountability, and not only to control the spread of COVID-19 and adapt to this new reality, while rethinking global health structures to safeguard and reinforce national health budgets for public health services and prioritize prevention, primary, and person-centered care. So as elected representatives, parliamentarians are the voice of the populations they serve. So to emphasize the words of my colleagues, for parliamentarians to adequately respond to their constituencies and address future healthcare needs, they must actively collaborate with community organizations and civil society. They are crucial stakeholders and the first line of defense on the ground. So their active engagement will support the development of people-centered health initiatives that are resilient and health systems that are sustainable. This must additionally be met with a multi-sectoral and health and all policies approach, while upholding timely, continuous, and sustainable investments to strengthen continuity in care and identify processes that are not working. Because disregarding gaps in universal access to healthcare services today will only exacerbate negative healthcare outcomes and promote health emergencies in the future. In addition to parliamentarians being accountable to citizens, they must also hold governments accountable. So they have the power to call on heads of states to uphold their commitments to the 2030 agenda as a framework and roadmap to achieve a healthier and more sustainable future, as well as the high-level political declaration on universal health coverage that we just discussed. It was adopted by member states just a year ago. So just to conclude, as we recognize this Universal Health Coverage Day, we must remember that healthcare is not a cost, but an investment. So health is a prerequisite for communities to survive and thrive. And through demonstrated political will, leadership, and accountability, we can ensure that everyone is protected and no one is left behind. So thank you for allowing me the short intervention.
Thank you so much, Victoria. It's so important. And I think through our, just between the interaction between our organizations and, you know, civil society working with parliamentarians, I mean, it's amazing how much that can be done and to understand how important the understanding between those two groups are really. So we've got about 4 minutes left. And we haven't spoken about COVID-19. It's, well, not very much. We touched on it a tiny bit. So there's a question in the chat that's addressed at Margaret, but I'll ask it to Margaret first, and then if other people have some comments about it, maybe you could just join in as well. So the question is, as we know now, the COVID-19 situation is, besides the pandemic, will have the biggest recession, will cause the biggest recession in the world. And we know that many health systems around the world can barely cope with this challenge. So the question is, what do you think about this problem, how this problem is going to develop in the future, and how will it affect the future of health systems? And I guess our journey towards patient-centered care in UHC. So Margaret, would you like to start?
Sure, thank you. I agree completely. We have a new level of challenge. Sorry, I'm hearing a lot of feedback. Is there something I can do?
It's me, let me.
Okay. Okay, I think that helped. Yes, absolutely. Economies have been scarred and set back, and it will be years before they recover the growth that they were realizing in the past in 2019. And of course, that has huge implications for health systems. I think that the investments that will be made in health systems going forward, though, have a chance to be examined in a new light because of this. I think we have a chance over the next few months, particularly as vaccines, I really hope, roll out in an equitable manner across countries, to take a fresh look at what has worked during COVID, what did we learn about the population and the health system, and which aspects of the systems were most functional and most valued, and really invest in those elements. Really, again, rethink, for example, a simple question that is not so simple to implement, but an important one, is how much care needs to be done in clinic with a provider, and which elements of care can really be shifted to users and communities. And again, the HIV community has been one of the vocal advocates in this over time, but we've seen many more people adopting some of the same strategies that have already been shown to be effective. If we do that and we focus the system on the areas where it's really adding the most value in the right place, without duplicating in theory services, right? Or on paper, or tokenistic, I love that word, services, because you can talk about tokenistic accountability. You can also talk about token services. Everybody knows it's not really there. we can get those out of those clinics and focus them where people will know they'll be delivered with high quality, I think we can realize efficiencies in the health system that we don't have today. Just as one example, you know, does every primary care clinic need to deliver babies? It doesn't do it very well, right? And it is a huge cost to be able to staff and equip those. With HIV care, how much of that, again, can be handled by pharmacists and community members themselves? So I do think that a crisis is also an opportunity to rethink some basic assumptions about care models, and I'm quite hopeful that we'll see that. In the meantime, though, let's use some of the investments that are being made. There are stimulus funds, there are loans and grants being provided that can also strengthen those health system elements. But let's not thoughtlessly pour them into things we were doing before. Let's just really think about what is the strategic best use of some of the new funds on board that are available to, for example, lower income countries.
Excellent. And maybe I have time for one more comment, Maka?
Yes, I want to comment about this challenging environments that are facing not only healthcare in total and governments, and but also civil society organizations that had very restricted resources to manage with these difficulties. During the first wave of the epidemic, we were very near to close because we were not equipped with needed equipment. We did not know much information about the virus and safety measures and so on. What's the situation do we have, not only Georgia, but most countries currently, that all human resources, financial resources, and diagnostic resources and treatment resources are everything moved only for COVID. Only COVID is taking place in entire environment. So from the civil society perspective, I wanted to highlight that countries and management should take care about the ongoing programs among them for marginalized groups, and those resources should be kept to keep the programs that were taking place before COVID, at least in the same volume as it was in the before the COVID era. Thank you.
Thank you so much. Yes, Sasha, please.
Yeah, very, very briefly. I think one of the great challenges and one of the great chances, and it's also very connected with what Margaret was saying about the people are really satisfied with the services. We've seen very huge distrust, I can say, towards the system. The reason why people are so resistant is because they don't trust the system can help them. They don't trust that this system is for them. And that's why they're resisting. And that's why it's so important to build really the system which is for the needs of the people, which takes into account what people think. The other hope, and at the same, I'm a bit scared of looking already when the first wave, when it came, the first wave of the COVID, all the governments, they were very, like, come, please, people in HIV, help us do this, help us do that. Can you please reform this or this? But when it became a bit better, well, being honest, the doors are closing again behind our noses. Thank you so much. Now we, like grown-ups, will do our business, and you can, go and do your stuff. And that's a bit scary. Like, I was thinking there is a chance for us, to start working really properly as equal partners. I hope it's still there. Thank you.
Excellent. Thank you so much. So that just leaves me a tiny bit of time to say thank you so much to all of our speakers and our panelists. It's been an incredibly rich session. I think that said a lot, but I think it's absolutely true in this case. And I certainly learned a lot. And it was great to hear all of your perspectives and have a great all-female panel, which I just kind of noticed in the chat before. It was amazing. So thank you all so much. Also, thanks to Terry and everybody at IAS for putting all of this together, and all the logistics and behind the scenes work they've been doing. I'd like to thank the Swiss Agency for Development and Cooperation, Merck Sharp, Dome, and other donors without which this webinar would not have been possible. And At the end of this webinar, you'll automatically be sent an evaluation, a link to an evaluation form. So if you could fill that out, we would really appreciate it. And thank you very much for attending today. Thank you very much for paying attention and being part of the UHC Day. And I hope to see you all again very, very soon. So thank you all so much.
Thank you.
Thanks, everyone.
Thank you.
Thank you.